Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be continuing in our head and neck cancer series with a discussion on squamous cell carcinoma of the oral cavity. If you've been following along with the series so far, we've had 2 lectures reviewing the anatomy of the disease sites and then the lymph nodes, and then 1 talk going over some general treatment principles for head and neck cancers, talking about the considerations for definitive versus postoperative radiotherapy, as well as when we think about adding concurrent chemotherapy to our radiation. If you've watched that lecture, you probably have a general gist of how head and neck cancers are treated. But what I'd like to do next in this series is actually go through each of the different disease sites and in further detail talk about different considerations for management. Because although they all follow a similar overarching paradigm, they each do have their own kind of unique considerations. So today we'll be starting out by discussing oral cavity cancer. I'm starting with oral cavity because it is one of the more common subsites of head and neck cancer, accounting for about 30% of head and neck malignancies. The majority of the time, so 95% of the time at least, these tumors end up being squamous cell carcinomas, which makes sense because squamous epithelium is what makes up our oral cavity. They do have a slight male predominance with a 3-to-2 male to female ratio. And they do tend to be associated with smoking and alcohol, as you can imagine, as well as chewing tobacco. Recall that there are 7 different subsites that make up the oral cavity. So these are the lip, the oral tongue, the floor of the mouth, the gingiva or the alveolar ridges, the buccal mucosa, the retromolar trigone, and then the hard palate. And typically, oral tongue and lip tend to be the most common subsites that we see in the U.S. In this talk, what I'd like to do is, as usual, start off with some background, including the presentation and workup of oral cavity cancers, talk about their staging and treatment paradigm, and then end with some evidence looking at some specific trials for oral cavity cancers that help guide our management. Let's get started with some background. Typically, oral cavity cancers are going to present with pain, and patients will notice pain when they are eating or chewing in a particular area of their mouth. They might have a non-healing ulcer. It might be associated with bleeding. If it's more advanced, it might be causing some dysphagia. Patients that have dentures might notice that their dentures are not fitting properly. They might have halitosis or bad breath associated with the tumor. And if the tumor is very advanced and invading into nerves or into the extrinsic muscles of the tongue, they might notice symptoms such as facial numbness, difficulty with protrusion of the tongue, or trismus if their pterygoid muscles are involved. And then in terms of exam findings, as you can see in the picture here, you might actually see a visible or palpable lesion or ulceration. And it might be associated with cervical lymphadenopathy as well. And the image here shows an example of a squamous cell carcinoma of the oral tongue. We already talked about smoking, alcohol, and chewing tobacco as some of the risk factors for oral cavity cancers. Other risk factors include factors such as poor oral hygiene or periodontal disease, having chronic irritation from ill-fitting dentures, betel nuts, chronic sun exposure, especially for our lip cancers, patients that have immunosuppression, so history of HIV or solid organ transplants, for instance. Chronically immunosuppressed patients are definitely at higher risk. And then it can also be associated with certain genetic syndromes such as Fanconi's anemia and dyskeratosis congenita. The workup is fairly standard, as it is with all other head and neck cancers. So we always start with a history and physical. You want to visually inspect the tumor, note the size and the location. And it's also important to palpate, wear a glove and actually palpate with your hand and identify where the tumor borders are and identify the dimensions and kind of in all of the different directions, anterior, posterior, superior, inferior, medially, laterally, where is the tumor extending? You definitely want to also perform a thorough cranial nerve and cervical lymph node examination. Note if there are any cranial nerve deficits. Note if you can palpate any cervical lymph nodes. And then it is also important to perform flexible nasolaryngoscopy just to rule out a second primary. In terms of imaging, a CT neck with contrast is going to be very beneficial for us to help delineate the primary tumor, also identify potential lymph nodes that are involved. A CT chest without contrast is necessary to rule out distant metastasis, as lungs are one of the most common places that these tumors are going to metastasize to. We definitely will consider a PET CT for nodal and distant staging. It can be challenging for assessing the primary, but it's very, very helpful to assess for involved lymphadenopathy as well as to assess distant staging. And then, as always, if there's any concern for perineural spread or if patients are presenting with cranial nerve symptoms, you want to get an MRI with contrast to evaluate whether cranial nerves are involved. In terms of pathology, this is often done in office, although depending on the tumor location, patients might need an exam under anesthesia with biopsy. And then standard evaluations that we perform for our head and neck patients, we always want them to have a dental evaluation. And this is very important because when we give radiation to the head and neck, one of the side effects is xerostomia or dry mouth because we do end up irradiating the salivary glands, and that results in decreased salivary function and dry mouth. And this can be very damaging with dry mouth. Bacteria is not kind of being rinsed off of the teeth as often because there's a lack of saliva, and so it can build up on the teeth and lead to increased risk of cavities. So we do always want head and neck patients to follow closely with their dentist, starting during radiation and continuing during the follow-up period. And during radiation treatment, we actually will prescribe a special fluoride toothpaste, such as Prevident, to help decrease their risk of cavities. Additionally, if patients have certain teeth that need to be extracted, we want those extractions ideally to happen before radiation takes place because there's evidence that for patients that have teeth extractions to irradiated area of the mandible down the road have an increased risk of osteonecrosis. So ideally, we perform tooth extractions before radiation. If it's delaying radiation or if it's not possible, we try to do it within a month after the radiation is over. But in the long term, we do need to take some special precautions to prevent the risk of osteonecrosis and kind of work with the dentist to identify which area of the mandible received the highest dose because tooth extractions after radiation can lead to an increased risk of osteoradionecrosis. So bottom line is dental evaluation is very important and patients need to be closely following with a dentist, not just before radiation, but also in the follow-up period for years after radiation is complete. Prior to radiation, we also really need to have our patients see speech and swallow and nutrition for evaluation of their speech and swallow function as well as their nutritional status. Many patients with head and neck cancer will not be able to adequately eat or drink due to dysphagia caused by their tumor. And as you can imagine, during radiotherapy, they're going to have significant mucositis on the inside of their mouth. That is going to affect their swallowing function, and that can then lead to poor nutrition because they're not able to get the nutrients that they need. So speech and swallow evaluation is extremely important, and they need to see a dietitian as well to talk about how to get adequate nutrition. If we are afraid that patients aren't going to maintain adequate nutrition or if they've already lost significant weight at the time that they come to see us, it might be important to get them a feeding tube. So this is usually a PEG tube that they get prior to starting any radiation. If patients are on radiation and they have typically 10% or higher weight loss during treatment, that's another time to strongly consider inserting a PEG tube because again, we know that these tumors make it hard for patients to eat and drink, and radiation makes it even harder. So weight loss is a significant side effect that does happen from radiation, and it's important to kind of upfront evaluate their speech and swallow function get them to see a dietitian and have adequate nutritional counseling and kind of monitor them through treatment. And then finally, we also want them to have smoking cessation counseling. And this is not on the slide, but if applicable, if they're having hear loss, you also want them to see an audiologist. Here's a slide just once again enumerating the 7 subsites of the oral cavity, and you should hopefully be able to kind of list these off the top of your head. I won't spend too much time here, but if you want more detailed review, I would refer you to the first lecture in this series where we in detail went through all of the different subsites and their anatomy. But just remember there are 7 subsites for the oral cavity, and if you can feel it with your tongue, it's probably part of the oral cavity. We also have a separate anatomy lecture going through the lymph node anatomy and reviewing the different patterns of lymph node drainage. And in that talk, there's a nice paper that I've referenced that actually lists out the different subsites in the head and neck and has tables kind of enumerating which specific lymph node levels you should think about covering based on which subsite is involved. So this particular table goes through the subsites of the oral cavity and indicates which lymph node levels we should think about covering. So we're always going to think about covering levels 2 through 4, which are kind of our standard cervical nodes that follow the path of the carotid artery and the jugular vein. So levels 2 through 4, we're always going to think about covering. Level 1A and 1B are our submental and submandibular nodes, respectively. So 1A is submental, 1B is submandibular. And for most oral cavity cancers, as you will see, the majority of the time, we're also going to think about adding coverage of level 1B. So most of the time for oral cavity, just remember we're covering level 1B and levels 2 through 4. If we have tumors that are kind of more anteriorly located, so think your lower lip, the tip of your tongue, the anterior floor of your mouth. We're also going to think about covering the submental nodes, which are level 1A. So it's almost always 1B and 2 through 4 for oral cavity coverage. And then we add level 1A for things that are more anterior and inferiorly located. So lower lip, tip of tongue, and the anterior floor of mouth. The most common histology, as we've already said, is squamous cell carcinoma, with about 95% of our oral cavity tumors being squamous cell carcinomas. Oftentimes, these develop from leukoplakia precursors, which have up to about a 20% risk of malignant transformation over 10 years. Less common histologies are things like minor salivary gland carcinomas, mucosal melanoma, lymphoma, sarcoma, and you might have skin cancers like basal cell carcinomas arising from the vermilion border of the lip. In my opinion, one of the hardest things about head and neck cancers is the staging, because every single site within head and neck cancer has its own staging system, and it can be really, really tricky to kind of learn that. So let's slowly go through the staging for oral cavity, and hopefully we can make it make a little bit of sense. And also, as we go through other disease sites, we'll spend quite a bit of time on the staging and talk about the parallels versus the differences between other sites. The T staging for oral cavity cancer is based on size and depth of invasion. So we care about these two things, size and depth of invasion. So the cutoffs for depth of invasion are 5 millimeters and 10 millimeters, and the cutoffs for size are 2 centimeters and 4 centimeters. So T1 is small tumors with low depth of invasion. So anything that's 2 centimeters or less with a depth of invasion that's 5 millimeters or less. That is considered T1. If it's less than or equal to 2 centimeters and has a depth of invasion that's greater than 5 millimeters, or if it's 2 to 4 centimeters with a depth of invasion that's up to 10 millimeters, then it's considered T2. So what makes it T2? If it has greater than 5 millimeters depth of invasion and it's smaller than 2 centimeters, or if it's 2 to 4 centimeters with a depth of invasion that's less than 10 millimeters. T3 then is 2 to 4 centimeters tumor with a depth of invasion that's greater than 10 millimeters, or anything greater than 4 centimeters with a depth of invasion that's less than or equal to 10 millimeters. And then finally, we get to T4. So T4 is divided into T4A versus T4B. T4A is anything greater than 4 centimeters with a depth of invasion that's greater than 10 millimeters, or anything that is invading adjacent structures. So that includes the mandible, the maxilla, the maxillary sinus, and the skin of face. So think adjacent structures that are just next to areas of the oral cavity. So the mandible and the maxilla are right underneath your gums, the maxillary sinus is right above the roof of your mouth, and obviously the skin of your face is right outside of the oral cavity. So anything that's adjacent to the oral cavity is T4A. A for adjacent. T4B then is kind of your more major structures. So tumor that is invading the masticator space, the pterygoid plates, the skull base, and or encasing the carotid artery. Anytime you have a tumor that's encasing the skull base or encasing the carotid artery, this is when we are thinking about T4B, and that pretty much applies to all head and neck cancers. So if it's wrapped around the carotid artery, if it's invading into the skull base, if it's invading into your pterygoid plates or your lateral pterygoid, typically that is what makes it T4B. In a nutshell then, that is the T staging for oral cavity cancers. That brings us to the nodal staging, which I think is actually very tricky for head and neck cancer. That is because there is a clinical nodal staging, and that is subtly different from the pathologic nodal staging. Now, the good news is that this form of clinical and pathologic nodal staging applies for the majority of cancers in the head and neck. The only exceptions that I can think of are cancers of the nasopharynx and then P16 positive oropharyngeal cancers. But other than those two sites, all of the different disease sites, so this includes oral cavity, P16 negative oropharynx, larynx, hypopharynx, they all utilize the same clinical and pathologic nodal staging system. So I would recommend spending a lot of time kind of memorizing this and then realize that it will apply for the majority of head and neck sites. So let's start with clinical nodal staging. N1 is if you have a single ipsilateral node that's 3 centimeters or smaller with no ENE, and ENE stands for extranodal extension. So a single ipsilateral node less than or equal to 3 centimeters without any extranodal extension. N2 is divided into A, B, and C. And N2 includes anything that's 6 centimeters or less in size. So N2A is anything that's a single ipsilateral node, 3 to 6 centimeters without ENE. N2B is multiple ipsilateral nodes that are 6 centimeters or smaller without any ENE. And then N2C is bilateral or contralateral nodes that are 6 centimeters or smaller without any ENE. So if you have a single node and it's less than or equal to 3 centimeters, then you're N1. If you have a single node that's between 3 to 6 centimeters, then you're N2A. If you have multiple ipsilateral nodes up to 6 centimeters, you're N2B. And then if you have a contralateral node or a bilateral node that's 6 centimeters or smaller, you're N2C. N3 then is divided into A and B. N3A is anything that's greater than 6 centimeters without ENE. And then finally, if you do have clinically overt ENE, then you are N3B. And you might wonder, how can you tell if there is clinically overt ENE? So what you do is you look at the scan, and on the CT scan, it really helps to have a CT of the neck with contrast. You look at the shape of the node and you look at the tissue planes around the node. If the tissue planes are disrupted, if it looks like it's invading into a muscle, if it has hazy borders, at that point, it looks like it has clinically overt extranodal extension, and that makes you N3B. So this is the clinical nodal staging for oral cavity cancers. There's N1, N2, and N3. And I would spend a lot of time kind of learning this clinical nodal staging. The pathologic nodal staging is essentially identical to the clinical nodal staging with one notable difference. So if you have a single ipsilateral node that's 3 centimeters or smaller and ENE is present on pathology, then it is N2A, so it's considered PN2A. Everything else is exactly the same as it was in the clinical nodal staging. So for the pathologic nodal staging, N1 is still a single ipsilateral node that's 3 centimeters or smaller without ENE. N2A still includes a single ipsilateral node that's 3 to 6 centimeters without any ENE, but it also includes a single ipsilateral node that's 3 centimeters or smaller with ENE present. N2B is still multiple ipsilateral nodes that are smaller than 6 centimeters. N2C is bilateral or contralateral nodes that are 6 centimeters or smaller. Again, no ENE for N2B or N2C. N3A is still any node greater than 6 centimeters without ENE. And then N3B is clinically overt ENE, but then the node has to be greater than 3 centimeters, or you have to have multiple nodes with ENE, or you have to have any contralateral node with ENE. So that is literally the only difference, is that N2A is a single ipsilateral node that's 3 centimeters or smaller with ENE present. And then here's the group staging for your reference. So we didn't go over M0 versus M1, but M1 is anything that has a distant metastasis. So if you have M1, it's automatically stage 4C. If you have T4B or N3 disease, it's stage 4B. If you have T4A or N2 disease, it's automatically stage 4A. And then if you have T3 disease or N1 disease, it's stage 3. T2N0 is stage 2, and T1N0 is stage 1. So I think if you think about, I think that this T staging and the group staging actually matches up pretty well. And if you're T1, you're stage 1. If you're T2N0, you're stage 2. If you're T3, you're stage 3. If you're T4, you're stage 4. If you are N1, you're stage 3. If you're N2 or N3, you're stage 4. I do think that the staging for oral cavity cancer takes a while to learn, and it's something that you kind of have to write out yourself and spend a lot of time staring at before you can memorize it. The good thing, at least, is if you memorize the clinical and pathologic nodal staging now for oral cancer, it's the same exact clinical and pathologic staging for many of the other subsites within the head and neck, including P16 negative oropharynx as well as larynx cancers. So that is the good part. Let's move on for now and get into some of the salient aspects of the treatment paradigm for oral cavity cancers. Oral cavity cancers are predominantly managed with upfront surgery whenever possible. The goal is to achieve en-bloc resection of the tumor. For early stage tumors, we aim for wide local excision. So if it's a tongue tumor, that might mean partial glossectomy. For more advanced tumors, the surgeries can be very, very invasive. So they might be something like a hemiglossectomy, a maxillectomy, or a mandibulectomy. And oftentimes these tumors, leave a significant defect that requires reconstruction. So if there's a mandibulectomy that's performed, patients might have a fibular flap reconstruction where surgeons actually take a segment of the fibula and use it to reconstruct the mandible after the cancerous part of the mandible has been removed. I have seen tongue tumors where patients had more than even a hemiglossectomy, and the area of the tongue that was missing was replaced with tissue from their leg. So they might require skin grafts, muscle grafts, bone grafts. The reconstruction for these tumors can be very intense depending on how advanced the tumor is. After surgery is completed, the indications for adjuvant radiotherapy are the same indications that we went over in our general principles lecture. So pathologic T3 or T4 disease, N2 or N3 disease, so these are kind of stage 3 to 4 tumors. If there's a PT1 to 2, N0 to N1 tumor with any of the following risk factors, such as LVSI, PNI, a positive or a close margin, something that's 5 millimeters or less, if there is greater than 4 to 5 millimeters depth of invasion, these are some risk factors that increase the risk of local recurrence, and that's when we think about adding adjuvant radiotherapy to reduce the risk of local recurrence. In terms of indications for adding adjuvant chemoradiation, remember the indications are positive margin or extranodal extension. So we think about adjuvant radiation for T3 to T4, N2 to N3, LVSI, PNI, close margin, or depth of invasion greater than or equal to 4 to 5 millimeters. And then we do adjuvant chemoradiation if there's a positive margin or extranodal extension. For tumors that are inoperable, so for example, if there's a T4B tumor that's far too advanced, or if patients are unfit for surgery, there's some options. Depending on the patient's performance status, functional status, we can consider either definitive chemoradiation versus induction chemotherapy to try and shrink things, followed by chemoradiation, or even immunotherapy in the upfront setting. And then if patients really have very poor performance status, we might just consider a palliative approach. So here are some more details around surgery for these patients. So remember, as long as it's possible to resect these tumors and as long as the patient is a good candidate, the recommendation is for upfront primary surgical excision, and the approaches can vary widely depending on the location and the extent of the tumor. So early stage cancers might be able to be resected with minimal cosmetic and functional deficits, but if disease is very locally advanced, then we really need extensive procedures, including things like hemiglossectomy, maxillectomy, mandibulotomy, again, depending on where the tumor is located. The key is to try and achieve a negative margin resection, and if a positive margin is present, then we really aim for re-resection whenever possible. And as radiation oncologists, it really behooves us to pay close attention to the operative report as well as to the pathology report, because sometimes, surgeons will have an area where there's a positive margin, and it might be along, say, a 4-centimeter area that there was a positive margin that was noted. It's really important for us to take a look at the re-resection, because they'll often have an area with positive margin, and then the pathology report will say that they went for a re-resection. If the area of re-resection is much smaller and that area looks like it has a negative margin, it's still possible that there is a positive margin, right? So if you take out a 4-centimeter area and there's a positive margin, but then the re-resection is only, say, 1 centimeter long, then we still have those additional 3 centimeters that might have been unaddressed. And this is, very, very challenging intraoperatively. It's also very challenging to interpret based on the operative report and the pathology report. So that's why multidisciplinary tumor boards are important. It's important to have, open conversations with the surgeon about how the surgery went, where they think the positive margin might be. Because when we're creating the postoperative radiation plan, it's really important for us to think about if and where that positive margin is located. And another factor, it has been shown in studies that when there is an initially positive margin that is then later resected and comes back as a negative margin, that is still a poor prognostic factor. So that is something that we need to keep in mind. Again, negative margin status is of utmost importance. The other point I'll make is about lymph node assessment. So assuming that the patient has N0 cancer, we need to have an elective dissection of at least levels 1 to 3. And if it's oral tongue, we ideally would want levels 1 through 4. If it is a well-lateralized tumor, we can consider ipsilateral elective lymph node dissection, but for more centrally located tumors that could drain bilaterally, they should ideally have a bilateral elective lymph node dissection. And again, certain early stage tumors that have a low risk of metastasis, so not a significant depth of invasion, something like a T1 upper lip, upper alveolar ridge, or hard palate tumor, they can be considered for omission of lymph node dissection. And then for certain clinical T1 to T2 N0 tumors, sentinel lymph node biopsy may be an option, and we'll talk about the data for that. In terms of indications for adjuvant radiation and or chemoradiation, these are the same principles that we've talked about in our general principles lecture. So remember, after surgery, it's very important to pay close attention to the operative report. And when patients have risk factors such as T3 to T4 disease, N2 to N3 disease, or if they have things like LVSI, PNI, if they have close or positive margins, again, pay attention to if it was an initially positive margin that was then re-resected. And then if they have a depth of invasion that's greater than or equal to 4 to 5 millimeters, then we think about adding adjuvant radiation. And standardly, the dose that we give is 60 gray and 30 fractions in the adjuvant setting. So typically 60 gray goes to the tumor bed, 57 gray can go to the operative bed, so everything that the surgery touched, including the dissected neck, and then 54 gray can go to the elective neck. And if patients have those additional risk factors of a positive margin and or extranodal extension, then we might need to deliver a sequential boost. So that is an additional 6 gray and 3 fractions for a total of 66 gray and 33 fractions. And then again, if we're going to give that sequential boost to 66 gray, the same indications are indications for concurrent chemotherapy. So typically if there's positive margin or extranodal extension, we add concurrent chemotherapy. And most often that is weekly cisplatin 40 milligrams per meter squared. With that summary in mind, let's now get into some of the evidence for why we do what we do, starting with some of the evidence for why surgery is the kind of gold standard for managing oral cavity cancers. The first study is a very, very small and old study from Glasgow. It was published in 1998, and it had only 35 patients. They had T2 to T4 and 0 to 2 squamous cell cancers of either the oral cavity or oral pharynx, but over 90% of the patients on the study had oral cavity cancers. And these patients were randomized to either surgery alone, followed by postoperative radiation to 60 gray, or radiation alone. Now, the trial was originally designed to accrue 350 patients, but they closed early because they saw a significant overall survival benefit with surgery. So at 23 months follow-up, they found that both overall survival and local control were significantly improved with the surgery arm. So you can see the hazard ratio for overall survival was 0.24 with surgery, and you can see the great difference in the survival curves that are shown in that Kaplan-Meier curve. And there was also improved local control with surgery compared to radiation alone. So this is an outdated and very, very small study, but again, it suggests that there were worse outcomes with definitive radiation alone compared to surgery followed by radiation. There was a larger study out of Singapore that ran in the late 90s and early 2000s that had 119 patients with stage 3 to 4 resectable head and neck cancers. And they were also randomized to surgery and comprehensive nodal dissection followed by radiation to 60 gray versus chemoradiation now, 66 gray and 33 fractions given with 2 cycles of cisplatin on day 1 and then day 28. As you can see, the patients were mixed in terms of their primary disease site. So 27% had oral cavity, but then they also had some larynx, oropharynx, hypopharynx, and sinus cancers. What they found is that there was an improved disease-specific survival with surgery in oral cavity cancer patients, but not in other disease sites or in other cohorts. So in the entire cohort, the 5-year overall survival was 45% versus 35%, not significantly different. The 5-year disease-free survival was 56% versus 46%, also not significantly different. In terms of the oral cavity and the sinus patients, however, those patients did have improved disease-specific survival with surgery. So the 5-year disease-specific survival for the oral cavity patients was 68% with surgery versus only 12% with chemoradiation. And for sinus, it was 71% with surgery versus 0% with chemoradiation. So oral cavity and sinus cancer patients both drove the improved disease-specific survival that they saw with surgery followed by postoperative radiation. So when we look at all of the different head and neck cancer sites, it seems like oral cavity in particular benefits from surgery with a postoperative radiation approach compared to definitive radiation alone, even if the radiation is given with concurrent chemotherapy. And that is where we get the paradigm of surgery whenever possible. The next few studies that I'd like to talk about discuss how we address lymph nodes, going over elective versus therapeutic lymph node dissection the role of sentinel lymph node biopsy for early stage oral cavity cancers, and then also some of the patterns of failure and where we see lymph node failures when we do see them. The first study we'll talk about came from Tata Memorial Hospital in India, and it randomized patients with T1 to T2 clinically node-negative oral cavity cancers to either elective ipsilateral neck dissection at the time of surgery or therapeutic node dissection. So that means that there was watchful waiting, and these patients just underwent resection of the primary, and if they had a recurrence, that is when they went on to get a neck dissection. So the other caveat of the study is that after surgery, any patients that had positive nodes, if they had tumor depth of invasion that was 10 millimeters or more, or if they had positive surgical margins, these patients did actually receive adjuvant radiation. The results of this study showed a significantly improved overall survival and disease-free survival with elective neck dissection. So the 3-year overall survival was 80% in the patients that had elective neck dissection versus 68% in the patients that had that watch and wait and therapeutic dissection approach. So over a 10% difference in survival. And the 3-year disease-free survival improved by about 25%. So it went from 46% with the therapeutic approach up to 70% with the elective dissection approach. And on subgroup analysis, they found a benefit to elective neck dissection across all subgroups, even in patients that had minimal invasion less than or equal to 3 millimeters. For the patients that were in the elective dissection arm, what was the rate of nodal positivity? So it turned out that 30% of patients in the elective dissection arm ended up having positive lymph nodes, and the risk of having positive lymph nodes increased sharply with increasing depth of invasion. So it's important to realize that, in this study, 30% of patients had positive lymph nodes, even if they were clinically node negative. And so elective lymph node dissection is really important. And in this study, it improved overall survival and disease-free survival. For the patients that were in the therapeutic arm, they were more likely to have a relapse with more advanced nodal stage, and they also had a higher risk of extracapsular extension. So if we don't do elective neck dissection up front and just watch these patients, they are more likely to present with disease that is harder to cure later on. So the big takeaway from this study is that patients with even early stage oral cavity cancer, so even T1 to T2 and 0, these patients should be having ipsilateral elective nodal dissection because this does improve overall survival and disease-free survival. Now, there is a commentary on this study that or rather a criticism on this study that the patients that had positive nodes went on to get radiation, and the fact that positive nodes impacted the radiation decision kind of biased the study and may have contributed to the improved overall survival. So that's an important kind of criticism to be aware of. But nevertheless, this study provides evidence that our patients with even early stage oral cavity cancer should be undergoing elective lymph node dissection. So understood, even patients with T1 to T2 node-negative disease clinically do need to have their lymph nodes addressed because they might have up to a 30% chance of having lymph nodes involved. The next question is, can these patients be treated with a sentinel lymph node biopsy, or do they need kind of a comprehensive neck dissection? There was a study called chemoRT that aimed to answer that question. So this was a phase 3 randomized trial of 300 patients with clinical T1 to T2 oral cavity disease or oral pharyngeal cancer. Now, 88% of the patients had oral cavity cancer, and these patients were randomized to either nodal dissection in the control arm or the experimental arm, which was a sentinel lymph node biopsy, followed by nodal dissection only if the sentinel lymph node biopsy was positive. The primary outcome was 2-year neck node recurrence-free survival, and they found equivalent outcomes between both arms. So both arms had just about 90% 2-year neck node recurrence-free survival. There were 16% of patients in the sentinel lymph node biopsy arm that ended up undergoing lymph node dissection due to node-positive disease on sentinel lymph node biopsy. What they found is that there was no significant difference in terms of any of the other endpoints, so the 5-year neck node recurrence-free survival, overall survival, disease-specific survival, or locoregional recurrence-free survival. And they found that the functional outcomes were significantly worse in the patients that had the lymph node dissection until 6 months after surgery. So based on this trial, chemoRT, and I'm not sure if I'm pronouncing that correctly, but based on this study, for early stage oral cavity cancer, so T1 to T2 node negative, we can pursue a sentinel lymph node biopsy approach followed by lymph node dissection only if pathologically node positive, because this is equivalent to upfront lymph node dissection in terms of oncologic outcomes and superior in terms of kind of that short-term neck function. And this trial concluded that sentinel lymph node biopsy for early stage oral cavity and oropharyngeal cancers should be standard of care. There is another Japanese study that was published in JCO in 2021 that actually shows non-inferior 3-year overall survival with sentinel lymph node biopsy as well, and it also shows better neck function. So sentinel lymph node biopsy is an option. But if you read the NCCN guidelines, it seems like it might have had kind of lower accuracy in certain locations, such as the floor of the mouth. That might be tricky technically for sentinel lymph node biopsy. So again, this is a discussion to have with the surgeons and to kind of keep in mind the location of the patient's tumor before we commit them to sentinel lymph node biopsy versus lymph node dissection. The big takeaway, though, is that their nodes need to be addressed some way or another. So whether that's sentinel lymph node biopsy, guiding our decision to pursue lymph node dissection for early stage, or just an upfront dissection, the nodes do need to be addressed somehow. So we realized that we need to address the lymph nodes. And it's also important for us to realize that when patients have lymph node failures, where are these failures? To kind of answer that question, there's a nice retrospective analysis looking at patterns of failure. That's a combined analysis of 160 patients that were treated between Memorial Sloan Kettering and Princess Margaret. So this retrospective study looked at pathologic T1 to T2 node negative oral cancer, specifically cancers of the oral tongue, that were treated with surgery and ipsilateral elective lymph node dissection. And these patients did not receive any postoperative radiotherapy. At a median follow-up of 66 months, so just over 5 years, there was an 89% rate of local control, 80% rate of regional control, and 86% disease-specific survival. Now, 20% of the patients on this study ended up having a regional recurrence, and those patients that had regional recurrence had significantly worse disease-specific survival. So it was 97% versus 33% if they had a recurrence. When they looked at where the recurrences were, in 60% of the cases, the recurrences were ipsilateral, but 40% of the recurrences were contralateral. So think about that. 20% of patients that were treated for T1 to T2 oral tongue cancers with surgery and ipsilateral elective neck dissection. So they had the full elective lymph node dissection. 20% of these patients ended up having a regional recurrence. And when that recurrence happened, 40% of the time, the recurrences were contralateral. So that is very important for us to keep in mind when we're thinking about where to give the radiation. We probably should be thinking about when to treat the contralateral neck. And the other important factor is that on multivariate analysis, tumor thickness of 4 millimeters or greater was the only predictor of regional failure. So for patients with tumor thickness less than 4 millimeters, the regional control was 94% versus 72% if the thickness was greater than or equal to 4 millimeters. And so the big takeaway from this trial, and the first author on this trial is Ganley. So the Ganley data tells us that for patients with tumor thickness of 4 millimeters or greater, these patients are more likely to have a regional recurrence, so about 28%, and 40% of these recurrences are contralateral. And this justifies kind of bilateral elective nodal irradiation for these tumors. And if you think back to our discussion on indications for adjuvant radiotherapy, Remember that depth of invasion of 4 millimeters or more, so 4 to 5 millimeters or more really, was a consideration and really an indication for adjuvant radiotherapy. So depth of invasion is part of our staging system, and tumor thickness in the Scanley data, 4 millimeters or greater tumor thickness was associated with significantly worse risk of regional failure. So that is why that factor is really important. And it's also important to keep in mind that 40% of the recurrences were contralateral. So we do really think about treating the bilateral neck. So just to summarize, here are some of the big takeaways from everything that we've talked about. Remember, we showed with 2 randomized studies that surgery seems to improve outcomes for oral cavity cancers compared to radiation or chemoradiation in the definitive setting. So upfront surgery whenever possible. And we do address the lymph nodes with elective lymph node dissection. If it's well lateralized, we can do ipsilateral. If it's a central tumor, we should have bilateral elective lymph node dissection. We should be dissecting at least levels 1 to 3 or levels 1 to 4 if it's a tumor of the oral tongue. And there are certain early stage tumors with a very, very low risk of metastasis per the NCCN guidelines that may be considered for omission of lymph node dissection. So T1 tumors of the upper lip, upper alveolar ridge, or the hard palate. Now, we saw with the sentinel study that sentinel lymph node biopsy may be an alternative, and we pursue full lymph node dissection only if sentinel lymph node biopsy is positive. And this can be an option for clinical T1 to T2 and clinical node negative tumors. But keep in mind that sentinel lymph node biopsy might be less accurate or technically challenging in certain locations, such as the floor of the mouth, the gingiva, and the hard palate. And then remember that for tumors that have a thickness or depth of invasion of 4 millimeters or greater, there's a very high risk of nodal involvement, which is about 28%. And when lymph node recurrence happens, about 40% of those recurrences are contralateral. So even if the patients just had an ipsilateral elective lymph node dissection, we really need to keep in mind the tumor thickness as well as other risk factors and consider bilateral radiation to reduce their risk of a contralateral recurrence. We will end by reviewing some of the data for adjuvant management with radiation, with or without chemotherapy. This slide is taken from our general principles of head and neck radiation talk, just reviewing some of the general indications for post-op radiotherapy, which we have already kind of reviewed. The criteria that are listed here in this box are criteria from the RTOG 0920 trial, which was a negative trial, but it randomized patients with undergoing post-op radiation for intermediate risk head and neck cancers to either radiation alone or radiation with cetuximab. So these intermediate risk factors that were used in this trial are really important for us to know. So T3 to T4, N2 to N3, PNI, LVSI, close or positive margins. And really, in this trial, it wasn't a positive margin, but it was a close margin that was less than 5 millimeters, or a positive margin that was then re-excised and negative, like we talked about. And any oral cavity tumors that were T2 with greater than 5 millimeters of depth of invasion were also included on this trial. In terms of timing for radiotherapy, it's really, really important for patients to have post-op radiation, ideally within 6 weeks of surgery. We do want them to heal from the surgery as well, so the ideal time to start radiotherapy is 4 to 6 weeks after surgery, and that has actually been shown to improve local control. There's a retrospective study out of Stanford that evaluated IMRT and looked for factors associated with local control. And they actually found that for patients that got radiation within 6 weeks, the local control was about 80%. But for those that had radiation greater than 6 weeks after surgery, the local control was cut in half to only 40%. And the authors actually also found a similar difference in terms of the total treatment package time. So less than 12 weeks versus greater than 12 weeks for the surgery and the radiation together. So we do really keep in mind that time interval. We don't want to delay surgery too much. And remember, we saw that with treatment breaks during the radiation, we talked about this in our general principles lecture as well, but we do try to finish radiation consecutively within 7 weeks once we get started, because for every day that radiation is delayed, we actually see a 1% decrease in local control. So treatment time for adjuvant radiation is really, really, really important. The indications for postoperative chemoradiation should hopefully also be a review from our general principles lecture. But remember that whenever there is extracapsular extension and or a positive surgical margin. So both of these are basically criteria on the pathology report that tell us there's microscopic tumor left behind. So whenever there is extracapsular extension or positive surgical margin, not only do we think about boosting to 66 gray, we also think about adding concurrent chemotherapy to the adjuvant radiation. So the data for this comes from two important trials that you should know, which are RTOG 9501 and EORTC 22931. So RTOG 9501 looked at risk factors, or looked at the addition of postoperative chemoradiation, and on their subset analysis that was limited to patients with positive surgical margins and or extracapsular extension, they found improved local regional failure and disease-free survival with the addition of postoperative concurrent chemotherapy to the radiation. And EORTC 22931 actually saw improved PFS and overall survival with post-op chemoradiation for a host of different risk factors, including clinical T3 to T4 disease, N2 to N3 disease, and any high-risk factors such as positive surgical margin, ECE, PNI, or vascular tumor embolism. Then there was a pooled analysis of RTOG 9501 and EORTC 22931, and on this pooled analysis, the only two risk factors that showed a significant benefit to the addition of chemotherapy were ECE and microscopically positive margins. So based on these two studies and their pooled analysis, we have data that patients that have extracapsular extension and or positive surgical margins should receive concurrent chemotherapy. And again, nothing in medicine is black and white, so the decision to add concurrent chemotherapy is very nuanced, and if there is a significant kind of perineural invasion or any of those other high-risk factors that were shown in EORTC 22931, again, a multidisciplinary discussion involving the surgeon and the medical oncologist is very, very important. To decide if we think we need to add adjuvant chemotherapy for other high-risk factors. But the textbook indications for adjuvant chemoradiation are extracapsular extension and positive surgical margins based on these two trials and their pooled analysis. So that brings us to an end of our discussion on oral cavity cancer. Again, as always, we are never, ever, ever able to discuss every single trial that's been done for a particular disease site, but hopefully this overview and the few selection of trials that we did go over kind of provide some context for why we do what we do when it comes to oral cavity cancers. And since, we're a little bit under an hour here and there's a little bit of time left, I'd like to make one last point that I didn't probably harp on as much as I should have when we talked about the treatment paradigm for these cancers and kind of the workup and evaluation of these patients. Many of the times when oral cavity cancer patients come to us in the radiation oncology clinic, they have already undergone surgery and they are just like 3 to 4 weeks out from surgery and they are just starting to kind of recover from some of the significant functional deficits that they have after removing a large chunk of their tongue or their mandible or their floor of their mouth. And so whenever we're having discussions about the benefits of adjuvant radiotherapy and the risks of recurrence if they don't pursue adjuvant radiotherapy, it's really important for us to be well informed and kind of identify these risk factors and, explain to them what the importance of adjuvant radiotherapy is. Because you can imagine as they are starting to recover, it's difficult for them to imagine putting themselves through either radiation or chemoradiation and kind of setting themselves back when they have just started to make progress after having surgery. The other thing that's really important for us to keep in mind, not just at the time of initial consultation, but also during treatment and in the follow up period, in the long term, really, is that head and neck cancer patients do have high rates of depression and even suicide, because the treatments that we give these patients for their cancers, and the cancers themselves can be very aggressive and cause a lot of bad things for these patients. And our treatments can also have severe, severe side effects for these patients. So that does lead to high rates of depression, and patients can commit suicide. So it's really important for us to be highly aware of that, and screening these patients for depression and suicidal ideation, and providing them with resources, including psychiatric referrals when necessary, to prevent that from happening. So we need to be very sensitive of this, and I think especially when we're counseling about radiation after a surgery has been done, I think that is when we really need to know our data and be able to inform these patients well about what their risk of recurrence is if they choose to not pursue adjuvant radiation. So hopefully this talk once again was helpful in providing a general overview of how oral cavity cancer is managed, a little bit of insight with the data as to why we do what we do, and I hope to continue creating videos in the head and neck cancer series, and we'll have similar talks for oropharynx, larynx, and so on. Thank you so much for your time and attention.